Hi everyone, I hope everybody's good today. This is Dr. A. We're going to go over blood diseases as part of clinical chemistry. So for a lot of this is going to be some hematology review really, but we do need to talk about it in the context of some of the chemistry tests that are done surrounding these blood diseases. Alright, so we're going to start with a poll question. So this is a case. So Annie is a 21-year-old college student. She has been vegetarian since she was 16. She has tingling in her feet. Her hemoglobin hematocrit is low, with a hemoglobin of 9.4 grams per deciliter and a hematocrit of 28%, which is also low. What type of anemia is most likely? So again, for that, just obviously she's anemic. That's the documentation. It's not terrible. But she's low enough to be tired, I'm sure. And then she has a tingling in her feet. She's vegetarian. She's 21. She's been vegetarian for quite a while. So of these possibilities, you probably should rule out hemolytic anemia right away because, I mean, that's antibodies to red cells. There's usually other more complicated diseases process involved there, maybe, or a drug or something that she'd been taking, and there's nothing of that in the history. Thalassemia could be possible, but with the cues on the case is probably not thalassemia, and usually that thalassemia is going to be diagnosed sooner than when you become an adult, but it is possible to get through to adulthood without knowing. So then it leaves you with iron deficiency and pernicious anemia, and actually either one of them would be likely, just because if she's not eating meat, it's possible that she would get less iron, although you can get iron from plants. But how well it is absorbed can vary. We tend to absorb some of those nutrients better from animal meats. From animal products such as meat than we do from plants. So it's in a different form. And so pernicious anemia is another consideration because you have the tingling in the feet. So pernicious anemia comes from a B12 deficiency. And vegetarian people, because they do not eat meat, are at a very high risk for being deficient in B12, and they need to supplement. So that if she hasn't, or maybe she didn't notice and she wasn't actively supplementing with B12 that was in the right format and was absorbable, over the span of quite a few years, she could definitely develop an anemia. You do store up some B12 in your liver, but you don't store up 5 years worth for sure. So in this case, what chemistry testing would you want to follow up with? So we did a CBC. See, she's got an H&H that's low. She's anemic. But we really, to know, is it iron deficiency? Is it B12? Like which one it is? We got to do some tests. So at a bare minimum, I would think that we would need to at least have a serum iron and probably a B12 and folate. There are other tests that we can do, and we're going to get into some of those. But that should be your bare minimum to try to distinguish what's going on with this patient, and then you can go on. Obviously, some of the info that wasn't there is some of the red cell indices can tell you, put you on the path to know if it was iron deficiency or the B12 pernicious anemia. All right, so let's review a little bit over hematopoiesis, which is the production of blood cells. Hemato is blood, not just red cells, blood cells. And they all start from a multi-potential stem cell. So these are what we often refer to as our bone marrow stem cells. And those can differentiate into either a myeloid stem cell line or a lymphoid stem cell line. So those are the two first big break-offs. And then within the myeloid, the myeloblast will give rise to basophil, eosinophil, and neutrophil or monocytic lines. Your megakaryocytes then give rise to your platelets, erythroblasts to your erythrocytes, and then the mast cells also off there off this myeloid stem cell. Mast cells, if you remember, are like basophils that are tissue bound. And then you have your lymphoid stem cell line, which then branches into your natural killer cells, and then your small lymphocytes, which is your B and T lymphocyte lines. The maturation process of these cells involve production of growth factors, and your body can produce those in response to needs. So cytokines or cytokines and growth factors enable then these progenitor cells, the stem cells, to differentiate further and to go down the line and put out more basophils or more eosinophils or more neutrophils or more erythrocytes, depending on the mix of cytokines and growth factors. Growth factors tend to stimulate cell division, and they can also regulate cell differentiation, so which line is stimulated. I won't ask you to remember or memorize this stuff, but just to give you an idea. So I know this is probably not super clear, but so you have your stem cells right here, and then these in these boxes are the cytokines and growth factors that these cells respond to either go down the lymphoid progenitor's line or the myeloid progenitor line. And so you see there are different interleukins that are in the mix here to make it go down one way or another. And then with the myeloid, and we have the basophils, eosinophils, granulocytes, which then become your monocytes, and that becomes the monocyte macrophage, and then this one will become the neutrophil. You make a karyocyte, which eventually becomes platelets. The erythroid progenitor cells, then they become red cells. So all of these, and then these are the different cytokines or growth factors that they respond to. And then this one, we have the pro-B cells, the pro-natural killer cells, and pro-T cells. Again, a different mix of interleukins. And then they become, your B cells can become your plasma cells. And then your natural killer cells are natural killer cell, progenitor, and then to mature. And then your T cells become, pro-T cells become your T cells. So anyway, we're not going to spend a lot of time on that. Just want to show you that. A little bit of review on white blood cells and their function. So in your peripheral blood, you should only see mature white cells. That's what's normal. If you see immature white cells, then it's usually an indication of a disease state. And the basic function of each white cell, the neutrophils, which are the most abundant, their function is to ingest and destroy foreign antigens, such as bacteria. Especially, they're really good at eating bacteria, but other foreign antigens. Lymphocytes, which is the next most abundant, they attack cells directly, like viruses. So that's your cell-to-cell immunity. That's your T cells do that. Or they produce antibodies, that would be your B cells. Against those antibodies against antigens that are foreign. Your monocytes are then the next most abundant, although really these two are the most abundant in monocytes. Usually about 10% of your cells are monocytes. They destroy foreign antigens and can also remove debris and dead cells. They're kind of your cleanup crew. Your eosinophils and basophils, you have usually really low number of those. The eosinophils respond to an allergic reaction and also to parasitic infections. And they would kick up in those circumstances. And then your basophils that contain histamine, which is also involved in allergic reactions, they're more common like in hay fever and that type of stuff. Okay, this is a little activity in the Nearopod. You're going to have to match what each of these are if you're in my class in the Nearopod activity. Okay, so now let's get into all the abnormal stuff. Let's start with the leukemias. So acute leukemias are malignant diseases of the bone marrow. Acute leukemias are more common in kids. The first one is your acute lymphocytic leukemia. It presents with anemia, neutropenia, and thrombocytopenia. So this is a lack of neutrophils, a lack of platelets, and then obviously here lack of red cells or hemoglobin or both. Approximately 10% of the patients can develop disseminated intravascular coagulation. So this is where there's clotting going on, microclotting going on all over the body, and that uses up all the clotting factors. So it's a clotting problem that eventually develops into a bleeding problem because all the clotting factors get used up. You see an increased cell turnover, and that results into high LDH as these cells get destroyed a lot faster than normal. So all your cells have LDH, so any of those increased turnover of those leukemia cells will cause an increase in LDH. And then uric acid, because that is the waste product of your purine metabolism, which is coming from your nucleic acids from DNA and RNA. Cells contain DNA and RNA, so if they're being turned over and destroyed at a higher rate, you're going to have an increase in uric acid. As your neutrophil count declines, then the patient can become more susceptible to bacterial infections, because your neutrophils are your main line of defense against bacteria. And the lymphocytes that are produced do not function as mature lymphocytes, so there's a bunch of them, but they're just crowding up the bloodstream and they're not actually doing their job. The next one is your acute myelogenous leukemia. So the lymphocytic was obviously in the lymphocytic line, and myelogenous is going to be in that myeloid line. And it's the main pathology is it's an arrested development of the myeloid progenitor stem cells. To diagnose acute myelogenous leukemia, there must be at least 20% blast in the bone marrow, so you have to do a bone marrow aspiration. Most of leukemias, you have to do a bone marrow aspiration to diagnose anyway. In the initial stage, you see a decrease in the production of your normal blood cells, so therefore you'll see anemia, thrombocytopenia, and neutropenia, just like an ALL. But then in the second stage, you would see a proliferation of the cells in the bone marrow and in the peripheral blood. So some of those earlier cells are starting to show up in the blood, and they're also proliferating in the spleen and liver, so you may get spleen and liver enlargements. So the problem is these cells do not go their programmed apoptosis. So some of those cells, like if they're like a neutrophilic line or something, some of them have, programmed apoptosis is usually not very lengthy. They don't live very long. So they don't die, and they're just hanging out there for a long time, and they don't function as normal neutrophils, which then lead, again, to an increase in bacterial infections. So AML patients may have also DSC, disseminated intravascular coagulation, and they frequently have elevated uric acid and LDH results. Both of these is same as for ALL, right? The DSC micro clots everywhere, uses of the clotting factors, and it's a bleeding problem, and then the cell turnover that can happen, this increased amount of cells being put out, and then eventually destroyed because they get stuck in places, and they plug up the microcirculation too, because the myelogenous lines, the myeloid lines, are bigger cells. And the bone marrow studies done and the test can be done to locate translocations or deletions on specific chromosomes to identify the different types. So there's definitely all kinds of, there's different ones, different classifications, so we're not going to go into that. Depending on which line is involved. So one was the lymphocytic line, this one's the myelogenous line. And then you have chronic leukemias. So chronic leukemias tend to happen more in adults. The first one is chronic lymphocytic leukemia. So it is a most common form of leukemia seen in adults, and it is generally asymptomatic. No symptoms. You have large numbers of small, non-functional lymphocytes in the bloodstream. They're seen as smudge cells on a peripheral smear. And you can do cytogenetic studies that can be used to confirm the diagnosis. People can live with chronic lymphocytic leukemia for a decade and not really have any kind of symptoms. Again, usually if it converts to an acute leukemia, then you can start seeing symptoms. Hairy cell leukemias, the lymphocytes have a hair-like projection on their surface, so they look hairy, basically. They look like they're surrounded with little hairs on the smear. They are, there's often extensive bone marrow involvement that leads to pancytopenia, meaning all the cells are decreased. So all the lines are affected. And cytochemical stains such as the acid phosphatase after tartrate incubation are useful to diagnosis for the diagnosis of hairy cell leukemia. Of course, in any of those you can do cytogenetic studies also. And then you have the chronic myelogenous leukemia, or CML. CML is characterized by the presence of that Philadelphia chromosome. I'll show you that here in just a second. The white count can be greater than 100,000, which is well, 100 times 10 to the 9, which is really big. Thrombocytosis is often present, but the platelets typically do not function well, and patients often have anemia and splenomegaly here with this chronic myelogenous leukemia. One thing to distinguish between the two, again, is the myelogenous lines, the cells are bigger, so they tend to create a little bit more problems, whereas the lymphocytic line, the cells are smaller, so the numbers can get higher before you actually see issues and some symptoms. And sometimes, again, with the chronic one, there's no symptoms. This is a Philadelphia chromosome, so it's a translocation, 922 translocation. So what happens is the tail end of these chromosomes here of 9 and 22 swap places. So the bottom of 9 ends up at the bottom of 22, the bottom of 22 ends up at the bottom of 9. So it's a translocation. And the Philadelphia chromosome is this chromosome 22 here with these 2 genes on it. All right, so next poll question. So do you remember which leukemia is most commonly seen in kids? If you're not sure, go back and rewind the video. Next one, so a little knowledge check. Which leukemia will show the Philadelphia chromosome, which we just looked at. So again, if you're not sure, just go back a little bit and answer that for yourself. Then we have myelodysplastic syndrome. So to break that down, myelo means bone marrow, and then dysplastic is a normal growth it's a syndrome. And so it's a primary neoplastic pluripotential stem cell disorder. So again, cancer-like, and affects the pluripotential stem cell. And so therefore the multiple lines that are involved, the cell lines that are involved are the erythrocytic, granulocytic, and the thrombocytic lines. And you see in peripheral smear a decrease in all the blood cells with one or more peripheral blood cytopenias, along with prominent abnormalities in the bone marrow. So the abnormal growth is dysplastic in the bone marrow, but then you get cytopenias in the blood smear. So leaving the leukemias behind. So leukemias all have abnormalities in the bone marrow, which affect the cells that are present in the peripheral blood. Lymphomas are different. So lymphomas are malignancies in the lymphatic system. Okay, so they affect the lymphatic system, not the cardiovascular system, not the bone marrow. So, and they are derived from abnormal B and T cells. So Hodgkin's lymphoma, you see abnormal B cells. It has 5 different classifications. The cause is unknown, although the Epstein-Barr virus can be linked to this disease. This is the virus that causes mono. HIV-positive patients have a higher risk of developing Hodgkin's lymphoma than the HIV-negative patients do. And the first symptom is often a single painless lymph node in the cervical region, and cervical meaning neck. So a big node in the neck on one side or the other. And the lymph nodes in Hodgkin's lymphoma contain Reed-Sternberg cells, which are staining particular histochemical stain here. Okay, so we are in the lymphatic system, so it affects your lymph nodes and lymphatic vessels. So the non-Hodgkin lymphoma originate either from a B line or a T line, B line, T line here, and has more than 30 different classifications, a bunch of different ones. The peripheral lymph nodes throughout the body will increase in size, so not just cervical, could be anywhere. And this disease has been seen in patients after exposure to pesticides, chemicals, and organic solvents. And like farmers are susceptible to this because of how much chemicals they're around. Peripheral blood hematology tests will reveal little to aid in diagnosis. So again, this is a big difference between the leukemias and the lymphomas is in the leukemias, there's usually something's off on the CBC in the peripheral blood. In the lymphomas, your CBC, your peripheral blood stuff will look normal, but the abnormality, again, is in the lymphatic system. Most lab results, including your chemistry results, reveal very just non-specific findings, nothing that just is really pointing to it. And so diagnosis has to be made from imaging studies like CT scans and biopsies, and obviously so revealing those enlarged lymph nodes and biopsying the lymph nodes to find out what's going on. Staging is the assessment of the disease progression. This is done in a lot of cancers, and this can help determine the type of therapy, and is also useful when monitoring the patient. All right, so what is the key difference, again, between the leukemias and the lymphomas? So think about that. If you're not sure, go back and rewind the video and watch. There are some key differences there between leukemias and lymphomas. And then this is a little activity for people in my class in your pod. All right, so moving on to the red cells. So we leaving the white cells behind, and we're going to start looking at hemoglobin. So hemoglobin is a protein that transports oxygen and carbon dioxide. However, it does not transport carbon dioxide the same way it transports oxygen. Just as a review, we talked about this a little bit in acid base, but your oxygen is transported onto iron molecules here in the middle of each of these chains, the globin chains. CO2 actually gets converted, and it can actually also just tag onto the protein part of the molecule, because CO2 is converted to bicarbon. That's how it's carried. But yeah, so a CO2 molecule can tag itself onto the globin portion of the hemoglobin molecule. So it generally has 4 globin chains, 2 alpha chains, and 2 betas. Okay, so the alphas here are represented in blue. The betas are represented in green, and then this orange dot in the middle of each of them is where your heme molecule is, where the iron is, and where the oxygen is transported. So that one molecule of hemoglobin can transport a maximum of 4 molecules of oxygen. All right, so iron is used throughout the body. It is found in myoglobin. It is attached to enzymes, so enzymes need iron to function. It is stored in tissues and in an iron circulating pool. In red cells, 1 iron ion is inserted into the center of the ringed heme molecule, and the molecule is inserted inside the globin, and 4 globins make a hemoglobin. It is important to know that, for example, iron is also used in the electron transport chain, in the mitochondria, etc., which is another reason why when people have iron deficiency anemia, they're really tired, because you need iron to produce energy, to produce ATP. Okay, and then iron is also, again, myoglobin is like a modified version of hemoglobin. It's just like muscle hemoglobin. It's muscle globin. And it can hold the oxygen in the muscles. So that's a variation there. So storage of iron. So let's talk iron and storage of iron. So ferritin is the primary storage form of iron. It is found in the liver, spleen, and bone marrow. And we can do ferritin levels on the blood, and a ferritin level then would assess your storage and storage capacity of iron. Hemosiderin is an aggregate of lipid, protein, carbohydrate, and iron. It is found primarily in macrophages and is formed from the partial degradation of ferritin. You would only see hemosiderin granules if you have excess ferritin, if there's really way too much to the point that it's degrading. Heme iron is found in red meats and is most easily absorbed than non-heme iron, which is found in vegetables and whole grains, although you can get it. But again, that's another advantage of having an omnivore diet. You don't have to eat nothing but meat, but having meat as part of a well-rounded diet does give you the advantage that you will absorb the heme iron better, and you're less likely to become iron deficient. So a little bit on iron absorption. So this is from the GI tract. So once you have ingested it and it's going down the GI tract, your iron has to be in a ferrous state to be absorbed. Apotransferrin binds ferric iron to form transferrin. So then it has to be converted from ferrous to ferric state for the apotransferrin to bind it. So the apotransferrin is the protein that picks up that transferred ferritin or iron, that transfer iron, there you go. And when it picks it up, it makes transferrin. So this is iron that's being transferred or carried in the body. This transports iron to the liver, which is where it is stored and throughout the body to meet the needs of the body. Again, remember, iron is needed for mitochondria. It's needed obviously in the liver. It can be stored up there. It's going to be needed in the bone marrow if you need to make more red cells. And the molecule hepcidin regulates the absorption of iron depending on your need. So let's talk about porphyrins now as part of red cells. So the porphyrins are composed of 4 pyrols. And this is a pyrrole molecule right here. So 4 of those bound in a ring shape, and this makes this porphyrin ring. And once you have the ring shape, it can bind the iron molecule in the middle. The side chains of the molecule allow for the variability of the porphyrins. There are bunches of different porphyrin types. The important ones that we're concerned with are uroporphyrin, protoporphyrin, and coproporphyrin. And in order to make heme, iron has to be in the ferrous state to be able to get in here and bind here in the middle of this porphyrin ring. And the oxygen binding is a process of an oxygen molecule that binds to one heme group, and it binds on that iron molecule. So let's talk about iron deficiency. So again, iron is an integral part of the hemoglobin molecule, so we need it to make a hemoglobin. But it plays a part in the peroxidase and cytochrome function. So again, more than just making hemoglobin. You need it for energy production. Peroxidase is the enzyme that is used for hydrogen peroxide to kill bacteria and stuff. So very useful. The consequences of iron deficiency can first, it leads to the production of small red cells. They're called microcytes or microcytes, and they have too little hemoglobin, and so they're hypochromic. So it's a microcytic hypochromic type of anemia. But cytochrome function is also affected. Therefore, you're not as good at producing energy. The patient would be more tired, and low energy would be a sign of iron deficiency. In your lab test, if you have iron deficiency, you would expect to see low iron levels, so lower than normal, or maybe even on the low end of normal. And your total iron binding capacity test, it measures the amount of iron that can be bound by transferrin, will be high. Because you have a low amount of iron, it has a high binding capacity. That means it's looking for it. It's wanting to pick it up. And so that's why the lower the iron is, the higher the binding capacity is, because it's wanting to find some iron because we need some iron in that body. And of course, if you have iron deficiency, the ferritin, which is the storage form of iron, is also going to be low. Now, on the other end, who can have iron overload? So women are more prone to iron deficiency because of the monthly cycle and bleeding of losing of blood. In men, because they don't have that monthly cycle, are more at risk for this iron overload. The most common form of iron overload is going to be hereditary hemochromatosis. And in this disease, you have a genetic mutation with an increased absorption of iron in the GI tract. And then, of course, because iron is valuable to the body, it's sent to storage. Where's the storage site? It's mainly the liver. But then, because there's excess, it's going to try to start stored in other places. And so you'll see it'll start accumulating not only in the liver, but in the heart, the spleen, and in the skin. And that leads to a bronzing of the skin because of all the iron that's in the skin, as well as a cirrhosis of the liver and diabetes. And this is both because of the way the liver is affected by all this excess iron. The lab tests that are done to diagnose hereditary hemochromatosis is going to be a genetic test and liver biopsy, quite involved. But the blood test, which we'd want to do that first because it's less invasive. You can do genetic testing on blood too. The liver biopsy is more invasive. Your iron levels, of course, in the blood would be high. The iron binding capacity would be low, and the ferritin would be high. So complete opposite of the iron deficiency. And the way you treat or manage this is to donate blood. So because you have the body has too much iron, if the person donates blood on a regular basis, then it forces the body to use up the iron to make more red cells, and it solves the problem. The alternative is therapeutic phlebotomy, where the blood is collected but then not used, which, again, if the person is eligible for blood donation, that's a win-win situation, because it's like they get the therapy and it doesn't cost them anything, and the blood can go help a patient. Actually, 4 patients. All right, so if your patient has iron deficiency, which set of results would you expect? High iron, high ferritin, low TIBC, low iron, high ferritin, low TIBC, or low iron, low ferritin, high TIBC. So if it has iron deficiency, if you're not sure, again, you can rewind and go back and look. If your patient has iron overload, would you see low ferritin or high ferritin? Which one you see if they have iron overload? Again, if you're not sure, go back to the iron overload section. All right, so let's talk about porphyria. So we introduced the porphyrin molecules, but if you have a problem producing the porphyrin molecules or somewhere in that production pathways, then a patient can end up with porphyrias. There's 2 big classifications of porphyrias. You have the acute ones and the chronic ones. The acute porphyrias are evidenced by periodic neurovisceral attacks, psychiatric symptoms, and red urine. And the most common of these is acute intermittent porphyria. Chronic ones, you get extreme sensitivity to the sun. The skin can blister, which then can cause infection and scarring. And the patients may develop liver and nervous system disorders, and the Porphyria cutanea tarda is the most well known. These are kind of known as the vampire diseases because they need blood, because some of them are not really good at making blood. You know, they have red urine, have psychiatric symptoms, they have attacks, they don't like the sun, and so these are called vampire diseases. So here's the production of porphyrin and heme. And so you can see there's enzymes are involved in all of these different steps, and depending on which one is defective, you have these different types of porphyria. So for example, if you have uroporphyrinogen 1 synthase deficiency or problems, then you will get acute intermittent porphyria. If there is a problem with coproporphyrinogen oxidase, you get hereditary porphyria. And so there you go. You can just kind of see, we're not going to go over all of them, but it's good to see what's going on there. And so basically you want to find what is accumulating and which enzyme is deficient to properly diagnose the patient and then manage the patient. A little bit on modified hemoglobins. So these tie back in kind of the acid-base chapter, but there are different forms of hemoglobins. These will all be measured usually by the co-oximeter on an ABG analyzer. The first form that can be measured is the carboxyhemoglobin. So this is hemoglobin that has been bound with carbon monoxide. And the binding affinity for carbon monoxide is anywhere from 200 to 150 times greater than that of oxygen, basically meaning if carbon monoxide binds on your heme, it's not letting go, and oxygen therefore cannot bind, and therefore you have a limited capacity to carry oxygen. And so if a carbon monoxide molecule is bound, then it decreases the oxygen affinity for the remaining subunits of the hemoglobin, the trimeter. Thus, CO2 not only decreases the oxygen content of blood, it also decreases the oxygen available to the tissues, meaning that if carbon monoxide is bound, it's going to hold on to that oxygen tighter and won't let go of it in the tissue where it's supposed to be delivering that oxygen. So there's a really real a problem here. The carbon monoxide is usually seen, poisoning or exposure is seen in fires, smoke inhalation, house fires, but also if you burn some certain types of fuel in the house that are meant to be outdoor, so like an outdoor camping type situation, but you're doing it inside and it's not well ventilated, and you can also accumulate carbon monoxide. Above a certain threshold, this can be lethal, but ideally, if it's lower than the toxic threshold, then the cells are just having to be destroyed and replaced, and the patient just needs to be have some extra oxygen or be on oxygen support. The other form is sulfhemoglobin. So it is another non-functional hemoglobin where there's sulfur involved here, a sulfur group. The oxygen in sulfhemoglobin cannot attach, so it's a non-functional hemoglobin. It cannot bind and carry oxygen. And this is a non-reversible condition and occurs usually after the ingestion of certain drugs like sulfa drugs, like sulfonamides. So this is drug-induced. And so again, it has to be pulled out and recycled. And obviously you want to withdraw the drugs so you don't keep having the problem. Then those patients cannot take sulfa drugs anymore and the hemoglobin will be replaced. Methemoglobin forms after the ingestion of nitrates, quinines, and aniline dyes. So again, kind of another drug-induced. It is also a non-functional hemoglobin. It cannot transport oxygen. And in methemoglobin, iron is in the ferric state instead of the ferrous state, and therefore oxygen cannot bind. So again, all three of those usually can be measured on a typical ABG. Okay, so which one of these was not triggered by a drug? So we have the choice. You can always rewind if you're not sure. Carboxyhemoglobin, methemoglobin, or sulfhemoglobin. And then moving on to hemoglobinopathies. So first we're gonna go into well, there's a whole bunch of them in the hemoglobinopathies, but hemoglobinopathies are mutations in the hemoglobin chain. So they're inherited variants. So these is something that is inherited through genetics. And if you think about it, so this is a protein, right? The globin chain is a protein. Proteins are made from a sequence of amino acids that have to be added, all the right amino acids in the right order to get a properly functioning 3D molecule that functions as the globin chain. And if you have a genetic mutation that swaps an amino acid for a different amino acid, then you're going to have some variations here in the way the chain is formed. Okay, there are over 900 ways this can go wrong. So over 900 mutations in hemoglobin chains have been identified. Most are asymptomatic, so most of them, the change doesn't affect its ability to transport oxygen. And but we're going to go over some of the ones that are more problematic. So hemoglobin E is a beta chain variant and is found in Southeast Asia with mild symptoms. Hemoglobin C is a beta chain variant with moderate anemia. And what happens is hemoglobin C polymerizes and forms short, thick crystals inside the red cells. So these hemoglobins polymerize and kind of stick to each other and form little hemoglobin crystals, which then, of course, they can't carry oxygen in that form. And then hemoglobin S, which is probably the one you're going to be the most familiar with, is also a beta chain variant. It can be fatal. So this is your sickle cell hemoglobin. And this one polymerizes into rigid aggregates that then makes the cell assume this crescent shape. So these hemoglobin molecules basically kind of stack and get stuck together in this like crescent shape, and they won't unstick. And so therefore then not only are the cells assuming the crescent shape, no longer they're biconcave discs, they can't flow through the capillaries as well, and they get stuck. So you get a hemolytic anemia, you can get vaso-occlusions because these cells get stuck because they're no longer flexible, and then you can get also overwhelming infections. The hemolytic anemia is obviously the cells as they change shape and you get stuck, they get destroyed, and so this is the hemolysis of the red cells. And this, interestingly though, gives the people that have hemoglobin S protection against malaria, which is also why it probably has stayed in the population so well. And hemoglobin SC is a combination of hemoglobin S and hemoglobin C. So it's two different beta chain variants, so two genetic mutations that are combined. So in contrast, your thalassemias are disorders of globin chain production. So your hemoglobinopathies are, there's a problem in amino acids being swapped around in your beta chains, where here we're having problems making them. And alpha thalassemia it's genetics. Obviously, all of these are genetic. Each parent contributes 2 genes, and in hemoglobin BARTs, there's no production of alpha chains, and you get a tetramer of 4 gamma chains is what's produced, and that's incapable of effective oxygen delivery, and it is fatal. And so they just don't live because you can't transport oxygen. Your beta thalassemias, and the genetics is each parent contributes 1 gene. We're going to look at those. So there are several types of beta thalassemia. There's beta thalassemia major, where 2 mutated genes are inherited. It usually becomes apparent during the first year of life. You produce more hemoglobin F, and you produce hemoglobin A2. So you get severe anemia with red cell fragments and microspherocytes. And in beta thalassemia intermedia and beta thalassemia minor, both involve a decreased production of these beta chains. So it's beta thalassemia because the beta chains aren't being produced appropriately, and they're being replaced by hemoglobin F or A2. The symptoms of beta thalassemia are going to be symptoms of anemia, therefore weakness, dizziness, shortness of breath upon exertion, tachycardia, and this all will depend, of course, severity of symptoms will depend on the degree of anemia that's been developed. Okay, so what, again, is the key difference between the hemoglobinopathies and the thalassemias? There is a key difference between the two. If you're not sure, rewind the videos and go back and think about it for a second. All right, and then let's go over your normocytic nomochromic anemias. So the cells are normal, the hemoglobin looks normal, they have the right color, but there's not enough of them, so there's still an anemia. So aplastic anemia is the first one. You get this bone marrow failure syndrome. It is acquired. It can be exposure to toxins or chemicals, but basically just quit making red cells. Not a good thing. So aplastic, no production here of red cells. You have anemia of chronic renal and endocrine diseases. These are simply the side effect of a decreased production in erythropoietin. So again, erythropoietin is produced in the kidneys. If there's chronic kidney disease, then this erythropoietin production is hampered. Erythropoietin is the hormone that signals the bone marrow to release and to make more red cells, and if there's not enough of it, then it's simply the bone marrow is just not getting the message to make more red cells. Some of this can be fixed by giving synthetic form erythropoietin to just take over the job or supplement so that they make enough because the bone marrow is fine. The bone marrow can make it. It's just it's not getting the signal to make it. Immune hemolytic anemias. Autoimmune. So these would be your transfusion reactions in hemolytic disease of the newborn. So antibody and antigen reactions where the antibodies are against the cells that have been transfused, or in hemolytic disease of the newborn, antibodies cross from the mom to the baby and is attacking the baby's cells. Or they can be autoimmune, like a cold agglutinin, where an autoantibody is tagging on the red cells and causing the destruction. So on this one, again, it's a hemolytic anemia, means hemolysis or destruction of the red cells. The red cells are being killed, and it's an immune system reaction to the red cells. Hereditary spherocytosis or elliptocytosis are membrane defects then that are causing an anemia. Glucose 6-phosphate dehydrogenase deficiency, or G6PD deficiency, also causes normocytic nomochromic anemia, and then paroxysmal nocturnal hemoglobinuria, which you have an absence of certain surface proteins, which leads to an uncontrolled amplification of the complement system and hemolysis, usually at night, right? And causes hemolysis and problems. So your macrocytic and your microcytic anemias. So the macrocytic ones are pernicious anemia and your folate in B12 deficiencies. So In pernicious anemia, the intrinsic factor is missing. And so you need intrinsic factor helps protect B12 in the stomach and then allow it to be absorbed in the small intestine a little further down. If you do not make intrinsic factor, it does not matter how much B12 you're ingesting or part of your diet, it's just not going to be absorbed. And so the lack of B12 leads to a macrocytic anemia. So folate and B12 deficiency are related, but instead of being the intrinsic factor that's missing, you simply don't have enough B12 or folate. And B12 and folate are needed for DNA synthesis, which is part of making red cells. So deficiencies of vitamin B12 then can also cause neurological issues. And so this was our first case that we led with. It's probably really a B12 deficiency, more than likely because of the neuro issues that can be caused. So the tingling in the hands and feet can be a B12 deficiency. So just not enough folate and B12 that's part of in the diet or being, usually it's part of the diet problem there. And then you have iron deficiency anemia. So your iron stores in the body are depleted and you're not absorbing enough, or there's not enough iron in the diet. This is a microcytic anemia. So it can be inadequate ingestion or inadequate absorption of iron. Or it can also be because it cannot incorporate the iron into the heme molecule, as seen, for example, in lead poisoning. And so all of those would be a microcytic hypochromic iron anemia, like iron deficiency anemia. So some of that can be fixed by supplementing with iron, and vitamin C is also necessary to absorb iron properly. Caffeine can work against absorption of iron, so you have to know kind of what to do here to be able to properly treat that. So the patient takes their supplement and it's actually getting ingested. Hemolytic anemias are, are they microcytic, macrocytic, or nomochromic nomocytic? So which ones did they fall under? And that was the classifications that we looked at in this presentation. So iron deficiency anemia, which one is it? Again, same three classifications. And so we're going to go over the common clinical chemistry tests for the next few slides. So iron is usually done by a colorimetric method. Iron has to be first released from transferrin, then released to the ferrous state, and then complexed with a chromogen, something that would change color as it's bound onto the iron, and the color changes proportional to the iron concentration. Pretty straightforward. That would be read by spectrophotometry. Total iron binding capacity, the excess iron to be added to saturate all binding sites is what's measured. The leftover iron is then removed, and that leftover iron corresponds with the total number of binding sites. And so that's, iron binding capacity. Both of these are quite often done in the lab, especially to assess iron deficiency anemia, which is quite common. And so again, iron and TIBC usually are performed together to provide a clinician with a percent saturation level, which is the percent transferrin saturation level also, which can be calculated using the TIBC and the iron levels. The ferritin, which is also commonly done along with iron and the total iron binding capacity. So again, that ferritin is that storage form of iron. And it's usually done by immunochemiluminescence, so it's an antigen antibody type of reaction and immunoassay. So again, quite commonly done in the big analyzers. These are less commonly done, but they can be done. So hemosiderin is detected using the Prussian blue stain of urine to look for those hemosiderin granules. And transferrin, if it's measured, it would be an immunoturbidimetric or immunonephelometric method, so another type of immunoassay. And transferrin is what is transporting iron. So the most commonly done, though, are going to be iron, total iron binding capacity, and ferritin. So to identify these hemoglobin variants, so a normal hemoglobin profile in a hemoglobin electrophoresis, you would see 95 to 98% of hemoglobin A, and hemoglobin A has those 2 beta chains and 2 alpha chains. 2 to 3% of hemoglobin A2 and less than 1% of hemoglobin F fetal hemoglobin. So electrophoresis can yield this hemoglobin profile with the different bands. You can also do high-pressure liquid chromatography to identify the different hemoglobin variants, and electron spray mass spectrometry. Any of these three can be done to then identify abnormal hemoglobins. In an electrophoresis, for example, so this is where you would see hemoglobin A2, hemoglobin F, and the majority would be here hemoglobin A. In beta thalassemia trait, you see more A2 and then some F, but then less hemoglobin A. This is compensated because it can't make those beta chains, right? In beta thalassemia major, you don't have any hemoglobin A because you're not making any beta chains, and you'll have nothing but hemoglobin F and hemoglobin A2. In sickle cell trait, this is, again, amino acid substitution in hemoglobin chain, hemoglobin S will migrate to this area right here. So if it's trait, so remember trait is half defective, half normal, and so the half defective is here, the half normal is here, hemoglobin A. And it's full-blown sickle cell anemia, so they have hemoglobin S from both parents. There is no normal hemoglobin at all. There's an increase in fetal hemoglobin, and you have a big, thick hemoglobin S band here in your electrophoresis. Other methods, DNA analysis. If there's family histories of hemoglobinopathies or thalassemias, you can do DNA analysis now. It's pretty easy, way more common than it used to be. Hemoglobin H identifications, you can do smears and stains for that. Hemoglobin S screening, so sickle cell screening. Blood can be added to sodium hydrosulfide and saponin, and hemoglobin S will appear cloudy, whereas the normal hemoglobin will be clear. And then to diagnose and monitor porphyrias, you definitely have to always protect a specimen from light. You can test urine, plasma, and feces to detect various compounds in the porphyrin process to see which enzyme is effective and what's accumulating where. And all of these are usually performed at reference laboratories as Porphyria testing. And that was your last slide. So again, thank you so much for your attention.